Thank you so much. I would now like to invite Dr. Seetharamu from Northwell Health to the podium for our next case presentation focusing on lung cancer.
Good afternoon, everyone. I hope to engage you after the post-lunch session. That was an exciting preview into what we're going to talk about, how all of that research goes into real world through some cases from my practice. So we're going to talk about case-based clinical updates in lung cancer. These are my disclosures. So what are the objectives? I hope to be able to convey the idea of identifying appropriate patients and procedures for lung cancer screening. I really want to start from the screening because I think prevention, early detection is really as important or even more important than even more important than talking about late-stage disease and metastatic second-line, third-line treatments. So I really want to get started with that because we often tend to ignore that. And then my focus today was, really, I know there's so many advances, but I don't have enough time. So let me just focus on early-stage disease, and then perhaps during the QA session, we can open up questions with regards to more advanced disease. So the last year has really opened our eyes into the era of neoadjuvant therapy for non-small cell lung cancer. So I'd like to review some of that, to understand current guidelines for adjuvant treatment for lung cancer, non-small cell lung cancer, and also to look at the current guidelines for management for locally advanced disease that's not amenable to resection, and to look at the role of molecular biomarkers in early stage lung cancer. So let's start with my first case here. I try to make it as interactive as possible. I know you don't have the clickers, but please, by show of hands, please feel free to raise your hands. And for those listening to this virtually, feel free to put your answers in the text box, or even it may help for you to look at this and see what you would do in this circumstance. So this is a 53-year-old man, current smoker with a 50-pack-year smoke exposure. He's 53, 50-pack-year smoke exposure, pretty intense. Mild COPD despite that. Remote history of testicular cancer 25 years ago, treated with surgery and chemotherapy. Comes in for a routine physical. He has no symptoms. His last visit to any doctor was 3 years ago when he had a chest x-ray and a colonoscopy, which were all normal per patient, and we were able to validate that. CT chest that was done 5 years ago when he was admitted for bronchitis had shown emphysema and some ground glass opacities. We were unable to get that record. He's otherwise healthy, very active. He takes a multivitamin pill a day. Which of the following screening procedures should he be referred for at this visit? Testicular ultrasound, any takers? Low dose CT, thank you. Repeat colonoscopy, chest x-ray, standard dose CT. Okay, thank you. So low dose CT, and the only reason, I mean, this is not, this has been around for a long time, but the only reason I brought this up is because there's a slight change in recent recommendations. But let's look at the NLST and the Nelson studies. We know that from several years ago now, that low-dose CT outperforms chest X-ray in reducing lung cancer deaths. There's a 20% reduction in lung cancer deaths when low-dose CT is utilized for patients at risk for developing lung cancer, particularly with regards to tobacco use. There are some, Nelson is another large study that was conducted in Europe, very similar design for the most part, but there were some differences. I just put them down here. In NLST, patients were randomized. In Nelson, they were randomized to a low-dose CT versus usual care, which was determined by the physician. Chest X-ray is not useful, we know that, so they looked into usual care. NLST looked at 3 consecutive yearly screenings. Nelson had a different timeline, year 1, 2, 4, and 5.5. NLST had a positive baseline screening of 24%. Nelson had 2.1%. Again, I think it's because of the population that we're looking at. False positive rates was very different in those 2 studies, and I think Nelson was a little bit more further out study, so I think we got a little better at reading the scans. Why am I presenting this? Because there was a recent update in 2021. The original guidelines, NCCN always had 55 to 74 years, current smokers or former smokers that quit within 15 years with a 30-pack year smoking history or family history of lung. They also take additional exposure like family history, personal history of another malignancy, history of COPD, or history of chemical exposure. And when the pack year comes down to 20 pack per year, the USPSTF, the old guidelines, 55 to 80 current smokers, and they had to have 30 pack per year smoking history. So the new guidelines moved the needle. So the patient that I presented actually is the poster child for why we need screening earlier. He is 53, he wouldn't fit into the guidelines as they existed before, but with the new guidelines where 50 to 80 years age group have been included and have a 20-pack year smoking, so much more generous than it was previously. And that is currently what we use in practice. It is an approved test. So of course, this patient did get low-dose CT. We did confirm that the scar-like tissue in the left lung is chronic. The new finding is on the right lower lobe. So what test would you order next? CT-guided lung biopsy, video-assisted thoracic surgery, open lung biopsy at the time of surgery and then possible lobectomy, PET-CT, PFTs, and I can't see the last one, but the timer is. Anyways, I don't need to know what that is, but anyway, PET-CT is what I would do because you want to assess that. So anyway, the result of the PET-CT here showed intense FDG uptake in the right lower lobe nodule. There was no mediastinal or distant disease. What is the next step in workup? Refer to thoracic surgeon. Repeat CT in 3 months. Refer for brain MRI. Send for CT-guided biopsy of right lower lobe nodule. Thanks. So here I think you could, I don't think it's wrong to go ahead with the CT-guided biopsy, but this is a high-risk patient. The nodule is highly suspicious. Doing a biopsy, what if it comes back as negative? Would you do anything different? I think in this case, you can go for CT-guided biopsy, then followed by surgery, but in this case, there's nothing else. All other sites are clean. I think I would refer the patient to a thoracic surgeon. So that's what happened. The patient underwent resection. The mass was 2.3 times 1.5 centimeter, lung adenocarcinoma. There was no other risk factors, no visceral pleural invasion, no lymphovascular invasion, no spread through airway space or perineural invasion are the risk factors that have been described. There was no nodal involvement. So essentially, this was a pathologic PT1C-N0 stage 1A3 as per the AJCC edition 8. There was no EGFR or ALK alteration, and PDL1 was 10%. What would you advise next? Adjuvant treatment with platinum-based chemotherapy followed by immunotherapy, pembrolizumab or atezo, adjuvant atezo or pembro only without chemo, no adjuvant therapy only if detectable ctDNA in peripheral blood post-surgery. Well, this is a stage 1 disease without the, and this is edition 8 I'm talking about. Even if you look at AJCC 7, this is still stage 1A. The tumor is less than 4 centimeters, therefore there is no role for any adjuvant chemotherapy. If you look at the, we'll talk about the IMpower study in a little bit, the IMpower 010. There was no benefit in stage 1A patients, and in fact any stage 1 patients, so we'll talk about that. So in this case, watchful observation or no adjuvant therapy with close monitoring would be appropriate. Everyone agrees? Thank you. So let's move on to another patient here. So this is a 79-year-old lady, former smoker. She quit in the 1980s. She had smoked for about 10 years. Prior to that, a pack a day, with history of hypertension, dyslipidemia, diabetes. She had a fall. She fell off of a bike. She's 79. I want to bring again. These are our patients. They're highly functional. They're 80, 85, 90 sometimes, and they're more functional than I am. So. That needs to be kept in mind. It's not the chronological age. Again, she had trauma to the chest. She was sent for chest X-ray, which found lung mass. CT chest showed a 4 times 6.3 times 5 centimeter right lower lobe mass. PET CT is shown below, quite obvious there. So there's the right lower lobe mass extending into the right hilum. And in addition, there is a subcarinal lymph node in addition to the right hilar lymph node. So she undergoes bronchoscopy and endobronchial ultrasound biopsy, pathology of level 7, so an N2 node is adenocarcinoma favoring lung primary because the markers are very specific here. And PDL1 is 0%. Sequencing of the tumor shows KRAS G12D mutation. So essentially, this patient has T3, N2, M0, 3B as per AJCC edition 2. And if you look at the edition 7, it's T2, N2, stage 3A. So now, I'll come back to this case, but the brain MRI is fine. The pulmonary function test is actually quite good. She is presented at the multidisciplinary tumor board, and the surgeons deem her as a surgical candidate. So let's go into some data here before we come back to the question. So now, resectable patients. So approximately 30% of patients with non-small cell lung cancer present with resectable early stage disease. So even with screening, even with everything that we are doing, we still are dealing with majority of our patients have advanced disease. And even after complete resection, there is a significant risk of distant metastases or disease recurrence. So the gains associated with the perioperative chemotherapy in the past have led to modest improvements in overall survival, though pathologic complete responses have been uncommon. This is with prior treatments. So now we're just, we have new data, of course, we're going to talk about. But let's for a second look at neoadjuvant versus adjuvant therapy. These are two meta-analyses here. On the left-hand side, you have the neoadjuvant, where you have preoperative chemotherapy in the red and no preoperative chemotherapy in the blue. There is multiple studies were included. This is actually quite old data, but it showed that there was benefit. So neoadjuvant therapy, why would we want to do that? So biologic advantages is that antigenicity. So the tumor is still in place. So you are able to educate the immune system while the tumor is in place. You can assess the response because the tumor is still in place. And then there is a lot of opportunities for window of opportunity studies and collecting biospecimen. We have shorter trial readouts. But then what is the potential harm here? So can you delay surgery? What about if the toxicity makes a surgical patient unresectable? So these are all questions that we have had for some time. So what about adjuvant? So here again, the curves are very similar. There's a 5% advantage. This is I think from the LACE study from a very long time ago. What are the advantages here? So you have the complete tumor in your hand, so you can assess the exact molecular profile of the tumor, and then they've already had their surgery, the bulk of disease has been removed, and then you're working on microscopic disease. So both of them have kind of pros and cons. But what is striking here, it's a cross-trial comparison, the curves are identical in these two. So whether you do it neoadjuvant or adjuvant, you gain benefit. So some of the perioperative trials, now we're moving on to immunotherapy space. We know that immunotherapy has made a huge splash in advanced setting. It's standard of care, as Dr. Porter presented, in advanced lung cancer. Frontline and previously we started with second, third lines, and now with frontline. And what about in the perioperative setting? So there are many studies now that have looked at many of these agents in the neoadjuvant and the adjuvant space. Now there are 3 FDA approvals. I didn't add the third one here, but there are 3 approvals. One is nivolumab in the neoadjuvant space with the Checkmate 186. We'll talk about that. Then we have the Empower 010 in the adjuvant space, and then we also have the Keynote 091 in the adjuvant space, all of which have led to FDA approval of these regimens in the neoadjuvant and adjuvant arenas. So there are a multitude of studies that have looked at the neoadjuvant particularly. The initial studies were small, N of 21. These studies showed that the pathologic response, which correlates for the most part with final outcomes, can be significant with addition of immunotherapy. Just with single agent nivolumab, the small study that was done at Johns Hopkins and MSK showed that the major pathologic response was 43% and a complete pathologic response was 14%. And then as you go on, you see more and more studies with increasing number of patients, and they all had the same theme. They either have immunotherapy alone or chemotherapy plus immunotherapy, varying number of cycles, but essentially they show the same. There are true pathologic responses. There are true complete pathologic responses. It varies. You add chemotherapy, you get a better response. The NADIM study, which we'll be hearing about, I'm pretty sure, in the next several conferences, had a major PCR of up to 75%. So let's talk about the Checkmate 816, which led to the approval of nivolumab with chemotherapy. which is really the, probably the most updated study that I'm presenting today. So this is a newly diagnosed resectable stage 1B patients, more than 4 centimeter. Again, this was AJCC 7th edition, and ECAR, good performance status, with no known sensitizing EGFR mutations or ALK alterations. And then they were stratified by stage and by PD-L1 status. Patients were randomized to nivolumab plus chemotherapy versus chemotherapy alone. Then they underwent radiologic restaging, surgery, and then following that, patients were really just followed up. Some of who received adjuvant treatment, but it was not part of the study. So the curves speak for themselves. Nivolumab plus chemotherapy outperformed, as you can see here, the median event-free survival was 31.6 months with a combination compared to 20.8. Almost all subgroups of patients benefited from it. There were some groups that I would like to point out here. Earlier stages, we spoke about it, early stage disease didn't seem to benefit as much. Low PD-L1, not so much. Never smokers, not so much. Patients with genetic alterations did not seem to benefit from this. So this is the pathologic CR, as you can see, quite telling here, 24% compared to 2.2%. We know that from prior studies, older studies, that pathologic CR is equivalent to improved outcomes, including survival. We know with other types of cancer, breast cancer particularly, that pathologic CR is equivalent to superior outcomes. So most of the neoadjuvant treatments are using that as a primary endpoint, I think, and that is completely okay. So overall survival thus far, it's not of course it's not mature, but definitely you see the trend towards improved survival as well. Hot off the press in the melanoma space, they looked at neoadjuvant compared to adjuvant, neoadjuvant or perioperative immunotherapy versus adjuvant immunotherapy, and showed clearly that neoadjuvant adds to the overall benefit. So that's something to keep in mind, and of course that's in melanoma, and hopefully we'll have similar studies in other diseases, including lung as well. So what about ctDNA? So the tumor DNA has been, circulating tumor DNA has been looked at. This is a hot topic from a biomarker perspective. This can be done in the office, very easy to do, easy to track. And in this particular case, it was not a primary objective, but this was definitely helpful. Patients who cleared the ctDNA after the combination or any treatment, neoadjuvant treatment, tend to have a very high PCR. So ctDNA can be extremely useful. And I use it in clinic in many circumstances, and we can talk about that at a later time. So the adverse effects, nothing that we don't know about, everything Dr. Porter just covered, so I am going to just skip this slide. This patient of ours, just to remind you, was enrolled in a neoadjuvant chemotherapy plus immunotherapy trial. She got 4 cycles, that was as part of the study. And as you can see, I don't know if you want to go back and see how the scans looked before, just to remind you, I spoke so much after that. This was how the scans looked before. And this is how it is now after treatment. So, now the patient undergoes right lower lobectomy, mediastinal lymph node dissection. There's just fibroelastic scar tissue. This is a complete pathologic response. Do we see that all the time? I'm very thrilled when I see this, but unfortunately that doesn't happen all the time, but we're seeing it more and more. Now, another patient here, a 69-year-old lady with a 40-pack-year smoking history. She underwent her first screening CAT scan and was unfortunately diagnosed with a lung RATS 4A, which is highly suspicious, lung nodule. PET scan, as you can see, quite telling. And you can see the measurements of the lesions here. So there was no clinical trial available at that time when she presented. So she was treated, did I tell you that? Okay, she had a biopsy, and this was squamous cell carcinoma. So she had an endobronchial biopsy as well, squamous cell. Surgeons deemed resectable. So she's again a resectable candidate. So based on Checkmate 816, we treated her with 3 cycles of cisplatin and gemcitabine. And as you can see, she's had, I only have CT images here. I couldn't get the PET images done somewhere else. But you can see the top one was before, and then the bottom one, you can tell, I mean, from any distance, you can tell that she has had a great response. This should have been before that slide, but anyway, this is a redundant question. So anyway, the options here were surgery followed by adjuvant, neoadjuvant chemoimmunotherapy, neoadjuvant chemotherapy followed by surgery. All of the above are appropriate. I want to argue here that neoadjuvant chemoimmunotherapy is the right answer here, because the surgeons may say they can operate, but the patient has disease in 4L, so that's an N2 disease. And there's another station, if you look at it, there's a hilar node as well, which you'll see. So there's 2 stations we know, and based on current data, even if the surgeons say for N2 disease, I think overall most institutions agree that some type of neoadjuvant therapy is necessary. Neoadjuvant chemotherapy alone, she does not have any contraindications for immunotherapy. There's no, neoadjuvant chemotherapy studies have not been really have not shown any benefit in the past, at least in a prospective setting. So I would argue that while in practice, any of these options may happen to this particular patient, the correct answer would be neoadjuvant chemoimmunotherapy. So after all of that, the patient underwent robotic left videoscopic left upper lobectomy with hilar and mediastinal lymph node removal. Pathology showed well-differentiated squamous cell carcinoma. The tumor was 1.4 centimeter. Previously, it was, you saw it was 4.5 centimeter or something. All margins were negative. It was a YPT1A, YPN0, but the percentage of viable tumor was 30%. So this does not fit into the criteria of complete pathologic response. This does not fit into the category of major pathologic response. But there is clearly a major radiological response. How would you tackle this? I don't know the answer. What is the most appropriate recommendation? 1 more cycle of chemoimmunotherapy followed by pembrolizumab maintenance, maintenance with atezo, close monitoring, thoracic radiation, postoperative radiation. I don't know what the answer here is. I chose close monitoring because we went with the Checkmate 816 regimen, and there is no adjuvant there, and she, in my opinion, has had a wonderful response. So we decided to do close monitoring. People may think otherwise, but that's what we decided. Also, I have been using the ctDNA monitoring here. Pre-surgical, you can see she had a detectable ctDNA. Post-operatively, bottomed out to 0, and at this point, she still maintains at a 0. So I'm very comfortable with the decision of just watchful monitoring in this case. Next patient, 72-year-old with hypertension, dyslipidemia, 30 pack year smoking history, found to have right lower lobe lung nodule on a screening CT. PET CT showed the 3 centimeter right lower lobe mass and hilar adenopathy. He undergoes surgery, so now he's not seeing us. He undergoes surgery, and the tumor is T2N1 adenocarcinoma, KRAS G12C mutated. Which of the following would be recommended? Adjuvant chemotherapy alone, adjuvant chemotherapy followed by pembrolizumab, adjuvant chemotherapy followed by atezo, adjuvant chemotherapy followed by sotorasib. Again, I can't read, but I think there is a PD-L1 of 0% there. I can't because of the time there. So how would you go about here? So anyway, adjuvant chemotherapy alone used to be the standard of care before. Adjuvant chemotherapy followed by pembrolizumab, new indication, regardless of PD-L1. In this case, the PD-L1 was 0%, and I think this is probably the most suitable answer. Adjuvant chemotherapy followed by atezo, only for PD-L1 positive tumors, and adjuvant chemotherapy followed by sotorasib, maybe in a clinical trial, but not as standard of care. So, so there are several adjuvant trials ongoing as well, and several have been completed, as we discussed. There are many other agents like canakinumab, we have durvalumab, the MERMAID study, MERMAID 2. There are several other studies going on, and again, the bottom line here is, they're looking at different immunotherapy drugs, and the duration is different. Perhaps the study itself, the endpoints might be different, but essentially they're all very similar. And we can see how all these studies pan out. The confusing part, and we can have an argument about this, is why PD-L1 negative patients benefited from in Keynote 091 and not in Empower 010. I don't know the answer, and I know Empower was not powered to look at that particular population, but that's something that's a hot debate at this point. So Empower, moving on to, this is adjuvant atezo versus best supportive care. Patients with resected tumors, stage 1B, tumors more than 4 centimeter or higher. Cisplatin, pemetrexed, gemcitabine, docetaxel of choice, 1 to 4 cycles, randomized to atezo versus best supportive care. Curves, or the Kaplan-Meier curves, are very clearly demonstrate the benefit of adjuvant immunotherapy in stage 2 to 3A population when PD-L1 is positive. So, and then in all patients, all randomized patients, regardless of PD-L1, you still see the benefit, but not as profound as the PD-L1 population. So what about all randomized patients, overall survival? This is stage 2 to 3A, and intention to treat is stage 1B through 3A. So if you look at all patients, regardless of PD-L1, the curves somewhat overlap. But when you separate it out with the biomarker status, there seems to be a benefit. But it should be kept in mind here that the PD-L1 was measured in various different ways in this particular study. The primary method was, they did SP263, they did the DACO22C3. Nevertheless, the bottom line is, PD-L1 positive patients seem to benefit, and in fact, PD-L1 50% or higher, so high expressors seem to drive most of that benefit. So majority of the benefit seem to come from that. These were all post-hoc analysis. The study was not designed to look at all of this. These were all backward analysis, and have to be taken with a grain of salt. So what about the overall survival in patients with a positive PD-L1? It was a clear benefit. The hazard ratio, it was trending towards clear. The hazard ratio was 0.71, but the upper bound crossed 1, as you can see here. This was last year. There's another update which I don't have here. But the side effects, again, nothing unusual as you would expect from immunotherapy. So the overall survival trend in favor of atezo in PD-L1 positive patients for stage 2 and 3A at the time of that analysis led to the approval of this drug in the adjuvant setting for PD-L1 patients with no known EGFR and ALK alterations. So one benefit favoring atezo was, the overall survival benefit was not seen in all patients. It was really PD-L1 specific. And now we move on to the Keynote-091. Similar study, PD-L1 testing was done using the 22C3 study, which is what we've been using with all studies involving pembrolizumab. Similar here, 4 cycles, pembrolizumab for 18 administrations, which is approximately 1 year, versus placebo. So this is a placebo-controlled study. The DFS overall, very clear. PD-L1 high patients, the curves are pretty clear. Actually, they're very similar in both. The p-value, in fact, is significant in the overall population, and not in the PD-L1 high population. I really have a very hard time understanding this. The numbers were very small. It was not designed to really look at the subpopulations, but we can have a discussion on that later on. But nevertheless, I think here, patients who had a history of smoking seem to benefit. Never smokers also benefited, even though the upper bound crossed 1 here. Pathologic stage 1B did not benefit. It was really stage 2 patients who benefited the most. And if they did not receive chemotherapy, they did not seem to have much benefit. Patients who had EGFR mutation, again strange, very few patients seem to have a benefit with pembrolizumab. Not sure, this requires a lot of investigation as to why the study has very contradicting results. But nevertheless, the story is the same. It shows that addition of pembrolizumab in the adjuvant setting post-chemotherapy is beneficial. So immunotherapy post-chemo in resected patients is the standard of care if they have not received neoadjuvant treatment. So this is the overall survival, not mature, trend towards improved survival. So last, I think this is 72-year-old woman, never smoker, presented for cough for 4 months. Chest X-ray revealed a left lung infiltrate. She was prescribed multiple courses of antibiotics without any improvement. PFTs are pretty good. This is her tumor, and you can imagine why she was treated as pneumonia. This is an infiltrating type of lung cancer, a very consolidative tumor. This is her PET scan. She underwent thoracotomy. These are gross images. You can see the tumor is really almost like a pneumonic type. It's really almost like a very, there's no mass here. It's just an absorbent lung, as you can see. This was the pattern. This is papillary, a typical adenocarcinoma that we see. So this was invasive, moderately differentiated adenocarcinoma. The tumor was 8.5 centimeter. There was visceral pleural invasion. There was no mediastinal or diaphragmatic involvement. There was no lymph node involved. Margins were negative. There was EGFR mutation though, but the PD-L1 was also 90%. What would be the next step in management? Cisplatin, pemetrexed followed by osimertinib alone, chemotherapy plus osimertinib, cisplatin, pemetrexed followed by atezo. Yeah. You want to, so 8.5 centimeter, clearly an indication for chemotherapy, EGFR mutation, osimertinib. So how do we know that? This is the ADARA study where osimertinib post chemotherapy, plus or minus chemotherapy post-operatively, clearly, I think you can see it from outside the building, the curves separate out, with regards to every endpoint here, disease-free survival, in stage 2 to 3A as well as 1B to 3A. All groups of patients benefit from this. So there is no doubt that in this case, I think, it's a clear answer. This is the last patient, sorry. 73-year-old gentleman with extensive smoking history was undergoing screening CT scans for a few years. 2016, it was apparently normal, but then he missed in 2017. 2018 showed a new lung nodule, 7 millimeters, and mediastinal lymph nodes. He underwent PET-CT, which showed no metastatic disease, but some uptake in bilateral hilum, mediastinum, in addition to the lung nodule that we know about. Patient is completely asymptomatic. He is, other than some intentional weight loss, his comorbidities are listed below. PFTs are optimal. This is his scan. So as you can see, he has uptake in both sides of the mediastinum, in addition to the tiny little nodule. So what would you now recommend? Surgery follows. The surgeons think he's resectable. They always do. Surgery followed. I'm just kidding. Sorry. Surgery followed by adjuvant chemotherapy, neoadjuvant chemoradiation followed by surgery, chemoradiation followed by durvalumab, palliative chemotherapy. Chemotherapy followed by durvalumab. This is the Pacific trial, progression-free survival, looking at durvalumab compared to placebo at 12 months, 18 months, and again, clear benefit. Median PFS was 16.8% versus 5.6% in the placebo arm, 12 months, 18 months, and now we have a 5-year update, all still standing strong. Overall survival hazard ratio 0.68 with a p-value of 0.00251. Definitely this is standard of care in unresectable patients. Clinical trials are definitely the best thing for any of these diseases, but I'm only talking about approved therapies and how we can integrate that into today's practice. And that is my last slide. Thank you so much. I'll look forward to the panel. Thanks.